Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Dr. Julian Tam, a respirologist at the University of Saskatchewan and clinical director of the Saskatoon Adult Cystic Fibrosis Clinic, discusses cystic fibrosis, its complications, treatments, and practical points for its care. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
I think actually the first time I've spoken to a group of anesthesiologists before, and I know CF is a very niche topic. There are, of course, times when our CF patients will encounter anesthesiologists, but I recognize they're going to only be in the minority of your practice. That said, as Henry mentioned, a lot has changed, and my goal today really is to make this presentation as anesthesiology adjacent as possible. As a quick let's not, we are going to start with a land acknowledgement. I acknowledge the history and respect the Treaty 10, 8, 7, 6, 5, 4, and 2 territories that Saskatchewan occupies on Turtle Island. As a newcomer, I arrived onto the traditional territory of many nations, including the Plains and Woods Cree, Dene, Nakota, Assiniboine, and Saulteaux, the homes of First Nations, Inuit, and Métis peoples, in the spirit of respect, friendship, and peace. I reaffirm my relationship with the First Nations, Inuit, and Métis peoples of Saskatchewan through supporting and uplifting Indigenous voices, taking accountability for my own learning journey, and serving as an ally as a healthcare provider and society member. Thank you very much for that introduction again, Henry. The quick housekeeping point I wanted to mention was that some of you may be aware that the annual Cystic Fibrosis Canada Walk to Make CF History Walk is taking place this coming Sunday. It's an annual CF fundraiser walk that's a lot of fun. On a personal note, I'm incredibly grateful to CF Canada because they supported my clinical training. They support our clinical and research work. They're a great charity. I think this might be the 7th year that I'm going on in participating in the walk. So if you and your folks have a free Sunday morning, early afternoon, you are super welcome to join us and show their Saskatoon CF clinics and friends. That's my team. You guys are very welcome to join us. Okay, learning objectives. We are going to discuss CF, current CF survival statistics. We are going to review the multisystemic complications of CF with a bit of a focus on lung disease. We're going to discuss various treatments for CF, including a somewhat new but still exciting class of medications called CFTR modulators. And finally, I will present some practical points in the care of people with CF that could well be relevant to your practices. Many of us are aware that CF is an autosomal recessive condition. It's caused by mutation of the CFTR gene on chromosome 7, which codes for the cystic fibrosis transmembrane conductance regulator protein, which is best known for functioning as a chloride channel. But in truth, it is also responsible for regulating the function of other ion channels as well. It is through CFTR protein misfunction that we encounter the various manifestations of CF. It's a multisystemic disease. There are various respiratory, GI, GU, endocrine manifestations. I've picked out certain complications, turned their font color into red because I have a feeling that these may be certain conditions that anesthesiologists might encounter more in a surgical OR or preoperative setting. I included that point about mental health down at the bottom because CF is not an easy disease to live with. There are many people with CF who encounter mental health struggles. In fact, it is quite well known that CFTR is expressed in neurons. We don't necessarily know for certain whether this is specifically the reason why people with CF have an increased rate of depression and anxiety, and there definitely is ongoing research on this topic. Shown here is a graphic from CF Canada's 2002 annual data report. If you haven't come across this this particular registry report before and are interested, CF Canada actually does put out an annual report with some, interesting statistics. It's an incredibly readable document. As you can imagine, there's always a bit of lag time between a particular year's data to when it gets presented. So I'm going to be showing some statistics from 2022. Shown in this graphic is the increasing prevalence of adults with cystic fibrosis over time. In 2022, adults represented about 2/3 of the Canadian CF population, and the median age of people with CF was 25.8 years. This graphic reflects the improving treatment and outcomes of people with CF over time, but it also makes us think about potential future health policy. If you can imagine, a pediatric CF clinic will always have the ability to transition their older teens to adult CF care, whereas for our adult CF clinics, we will continue to look after patients. So this is a statistic that I sometimes do share with important policymakers when it comes to thinking about resource allocation and planning for the future. Let's chat about a couple of survival statistics. The median age of death in 2022 for Canadians with CF was 38.4. Median age of survival was 59.9. Let's chat about what these numbers actually mean. The median age of death is the easier number to understand. It's simply taking into account everyone who has passed away in a given year, picking that median value once they're sorted in ascending order. The median age of survival is a calculated age that predicts for babies born today what is the age at which 50% of those babies would be expected to survive past. This chart shows the overall increasing trend of the median age of death over the past couple of decades. As you can imagine with this kind of statistic, there's always going to be fluctuation from year to year. And shown here is the also improving trend of the median age of survival over time of Canadians with CF. It's pretty darn impressive to think that we're now, just shy of 60 years. Taken together, people with CF are living longer and longer, but CF still has the potential to cause morbidity and mortality at an early age. Briefly, to diagnose cystic fibrosis, we can make the diagnosis in people with clinical features suggestive of CF, either with a positive sweat chloride test or 2 CF-causing CFTR mutations. There are many, many, many CFTR mutations which are known of. Some of them are known to be disease-causing, CF-causing. Some of them are known to not be CF-causing, and some of them are just of uncertain significance in our current era. So there are indeed some people who have clinical features in keeping with CF, but may not necessarily meet full diagnostic criteria. For instance, with intermediate sweat chloride testing and fewer than 2 disease-causing mutations. It is fair to ask, do we sometimes come across milder phenotypes in these patients? Sometimes, but at the same time, we also can encounter severe disease, and potentially these folks may even go on to require lung transplant too. In 2022, there were 80 new diagnoses of CF in Canada, with the majority diagnosed via newborn screening. However, it is known that although the majority of people with CF are diagnosed early in life, adult diagnoses can totally occur as well. This is something that I always make a point of sharing with the medical learners that I work with, because there may be instances where a person had a milder phenotype, milder mutations, and yet with various manifestations of CF. we know that newborn screening for CF only started in Canada back in 2007. So there is a cohort of Canadians who did not receive newborn screening, may have just, slid through the healthcare system with, perhaps milder manifestations of CF, but these things can worsen over time. So for the learners I work with, I share with them that if a person has clinical features in keeping with CF, and they've never been tested for it before, in the appropriate context, usually when their lung issues develop at an early age, I do encourage for the consideration of sweat chloride testing. So we know that there are various classes of CFTR mutations. This on the graphic on the far left represents a normal cell with normal CFTR, which is this green ion channel that is on the cell surface where CFTR needs to go. Briefly, Class 1 mutations are characterized by a premature stop codon. Essentially, there is no CFTR that's made at all. Class 2 mutations are characterized by an error in processing. So CFTR is made but does not get folded normally, does not make its way to the cell surface. Class 2 mutations are the most common class of CF mutations. The most common CFTR mutation worldwide is F508L, which is also known as Delta F508, depending on the nomenclature scheme that's used. You might find me, using these terms somewhat interchangeably, just out of habit and whatnot. Class 3 mutations are characterized by an block in regulation. We have CFTR that makes its way to the cell surface, but it does not respond normally and open in response to ATP stimulation. Class 4 mutations are somewhat similar in that we also have CFTR that makes its way onto the cell surface, but there's altered conductance. Chloride does not flow through normally through the cells. And with class 5 mutations, there's otherwise working CFTR that gets to the cell surface, but produced in either insufficient quantity or perhaps there is an increased turnover rate. I will confess that this is a bit of an oversimplification of things because CFTR is kind of complicated, but I think having a basic understanding of what I just discussed will be helpful in understanding how some of these newer medicines work. I always feel like a dork when I, try to cram CF lung disease pathophysiology in a single slide, because there are many, many, many scientists who have committed their lifetimes of research to understanding CF lung disease. The truth is, even after all these years, there are still unanswered questions about CF lung disease. But of course, this is supposed to be, a clinical presentation. So I'm going to compress things as in as a meaningful a way as possible. So at its heart, CF lung disease is a disease of epithelia. There is something that we don't talk about very much in clinical practice, even in internal medicine, respirology, something called airway surface liquid. This is not sputum. This is this microscopically thin layer of fluid that lines the airways. And it has been shown that abnormalities in airway surface liquid play a role in causing CF lung disease. Many, many, many people are familiar with the idea of airway dehydration, but abnormally viscous, abnormally acidic, ASL has been shown to play a role as well. Again, in broader healthcare, society, we often think about chloride, but the truth is sodium bicarb play a role in CF lung disease pathophysiology as well. Ultimately, it's complicated because there are going to be abnormalities in innate defense in our people with CF. It's been shown that there's neutrophil dysfunction, chronic infection, chronic inflammation are contributory as well. Many of you are aware that the hallmark of CF lung disease is bronchiectasis. By the time a person has well-established lung disease, chronic infection, we think about these inspissated secretions that predispose a person to recurrent episodes of infection, lung injury, and eventually end-stage lung disease can happen. CF patients can be chronically infected with a variety of organisms. They don't stay static over time. Earlier on in life, MSSA is the most prevalent organism. Later in life, Pseudomonas becomes the most common. And that's not to say that we don't necessarily have young people who grow Pseudomonas or patients with well-established disease who grow only staph. But these are general figures and statistics to consider. Our patients are vulnerable to developing pulmonary exacerbations. There's no universally accepted definition of them. Clinical trials will define them as a change in antibiotics in response to at least four of a series of symptoms, including worsened respiratory symptoms, constitutional symptoms, lung function, imaging decline. So these things can totally happen to our patients. Unlike, for instance, community-acquired pneumonia, COPD exacerbations, we use somewhat different antibiotics. We use previous sputum microbiology to guide our selection of antibiotics. So if a person consistently grows staph, I will allow myself to, simply prescribe them cephalexin or some anti-staph antibiotic. And if we have people who consistently grow Pseudomonas, we will often just start them right there and then with anti-Pseudomonal coverage. Because of antibiotic resistance, we will sometimes use antibiotics less commonly used outside of the CF population. We can use oral antibiotics for milder exacerbations, IV antibiotics for more severe exacerbations, and we will often consider home IV antibiotics when we have an appropriate situation. Just as a few practical points, in vitro CNS don't always predict clinical response. There's various reasons for this, including the fact that it is pretty well known that people with CF don't always grow a single strain of a particular organism. A single sputum culture may not actually reflect the multiple strains that's in a CF person's lungs. Some of the higher doses of antibiotics we use might be able to overcome certain resistance patterns. And beyond that, CF lung disease is just complicated. It is known also that patients with CF have altered pharmacokinetics. So again, we will sometimes just use higher doses of CF antibiotics. We continue antibiotics until a person is back to baseline, which is a minimum of 10 to 14 days of antibiotics. And sometimes longer. I mean, there are totally people who will stay on antibiotics for weeks and weeks and weeks until we get back to where we think they are. We don't routinely use systemic corticosteroids. So even though CF is, classically thought to have an obstructive pattern, it usually does. Though there are instances where mixed obstructive restrictive processes are possible, we don't routinely use prednisone or other systemic steroids unless there's an asthmatic component at hand. And ultimately, lung function does not always recover back to baseline. So one of our goals indeed is to try to, how should I put it? Recover a person to baseline, treat them as aggressively, but hopefully also prevent the development of the exacerbations in the first place. Okay, I see that we have a question in the chat box. I'm going to answer this question now because it's probably fresh in our heads. I'll make a point. I definitely have some time left over at the end, so we'll be able to take care of all remaining questions at that point. So the question was, do mutations overlap, and does that have clinical implications? So that's actually a really, really neat question. At the end of the day, CFTR mutations are also kind of complicated, and there are instances where the mutations will perhaps be classified in a different way. So for instance, some clinical trials have looked at minimal function versus partial function mutation. So, based on either epidemiologic data, in vitro data, whether some mutations might have essentially very, 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 very little to no response, or at least some partial response as well. Using the nomenclature scheme that we use, do they overlap? Not exactly, because for instance, something like, well, actually, I was going to say typically not, because at the end of the day, F508del, it at its heart, it is going to be a class 2 mutation, and we're typically not going to see CFTR get onto the cell surface. But through some certain treatments that we use, even if we get it to the cell surface, it still doesn't function normally. So there is still there is still going to be CFTR on the cell surface if it gets there pharmacologically where it doesn't open up normally. So yeah, that's a guess of I hope that answers the question. So in essence, for the most part, typically we don't think about overlap in the mutation classification scheme that I presented. Thank you. Okay. So maintenance treatments for CF lung disease. Airway clearance is a very old school standard of care. There is really no one size fit all for everyone. So some of you may have heard of these things called PEP devices. There are these oscillatory PEP, like positive expiratory pressure devices. Some people use vests, although the strategy is less common in Canada versus the United States. And it really, like, I mean, evidence doesn't show any superiority of the vest over more other sorts of like less fancy treatments. Ultimately, our physiotherapists will work with our patients to decide on a regimen that fits best for them and their lungs. We will often recommend nebulized treatments to facilitate airway clearance. Dornase alpha recombinant human DNAs will help break down the dead white blood cells in a person's secretions to thin out the secretions. Nebulized hypertonic saline, which is a topic near and dear to my heart because that's something that my research team does research on. It is best known for helping restore airway hydration in dehydrated CF airways, but using the synchrotron, we've also shown that hypertonic saline stimulates the nervous system to increase airway liquid production as well. For our patients who are chronically infected with Pseudomonas, we will routinely recommend the use of inhaled antibiotics as well. So whether it's tobramycin, aztreonam, colistin, there are some folks who will also use like inhaled levofloxacin as well. There's no clear-cut evidence to support chronic antibiotic use in people who are chronically infected with other organisms. So, for instance, if we have a person who's chronically infected with MSSA, it's only the minority, very small minority of the time that I would offer chronic cyclical antibiotics. And that would mainly be the folks who have very frequent exacerbations, who just can't stay well, oftentimes despite their best efforts, or, despite their best efforts in just a bit of a harm reduction kind of way. So again, it is quite common for our patients to be on inhaled anti-pseudomonal antibiotics, less commonly for other organisms. Azithromycin has been shown to be beneficial to patients chronically infected with Pseudomonas, which may come as a bit of a surprise because, of course, azithromycin, not an anti-pseudomonal antibiotic. Rather, it has been shown to have some anti-inflammatory / non-antimicrobial properties. And of course, lung transplant is a discussion for a different day, but it is offered to people, including with CF, with advanced lung disease. If lung transplant happens, we will routinely recommend double lung transplantation because in broad strokes, we don't want the infected secretions from a person's old unhealthy lung to spill into the new healthy lung. And lung transplant can improve quality and quantity of life in our patients. So this is maybe a deliberately busy slide for dramatic purposes to show the various medicines we put our patients on because our patients totally do fit. We do ask a lot of our patients. They bear a heavy weight of burden of treatments. Shown also on this page, though, is aside from these medicines called CFTR modulators, over the decades, the vast majority of our treatments have really just focused on treating the end organ complication of CF. The CF mutation was described in the late 1980s, and at the time, it was thought that gene therapy would be right around the corner. But gene therapy is incredibly difficult to do, and I mean, it's still really not a part of current clinical practice. So as a result, we were treating those end organ complications. If a person had infections, we give them antibiotics. If they have thick, sticky secretions, we give them inhaled mucolytics. But that segues into our discussion about CFTR modulators. So this is a somewhat new and still exciting class of medicines. I say, somewhat new because really the landmark paper that came out about the first modulator that came into the market was from back in 2011. I was still in training at the time. So each year that goes on, I kind of like change the qualifier from new to relatively new. So now I'm at the somewhat new stage. We're going to talk about these medicines. So, the first one I want to present is ivacaftor. So again, this is the first modulator that made its way into widespread use. We will recall that class 3 mutations are characterized by CFTR that gets to the cell surface but doesn't open normally to ATP stimulation in the hand-waving kind of way because these things are complicated. Ivacaftor is a potentiator. So it is a medication that actually increases the open probability time to allow that, chloride channel to function better, chloride flows through at a better rate. It was huge because when this medicine was used for the appropriate patient, we were seeing huge gains in lung function. People were getting delisted from lung transplant because they were that good. People were coming off of supplemental oxygen. There was improvement in quality of life, nutritional benefits. It was a game changer. But at the same time, these class 3 mutations are rare. And I should mention that though G551D was the mutation that was studied, there are other class 3 mutations as well. Like we're talking about like roughly 5 percentage points of like CF patients in total. So we needed stuff for everyone else. On an aside though, there's no reason you need to memorize this at all. Ivacaftor can also help out with those patients with class 4 mutations too, but those folks are also a relatively rare proportion of people with CF. So fast forward a number of years, there were a couple of other modulators that came out. I should mention as well, just going back one slide. So I use generic names out of good practice, but the trade name for ivacaftor is Kalydeco. You may have come across that in like mainstream media as well. So again, fast forward a few years, a couple of other modulators came out, something called lumacaftor ivacaftor, also known as Orkambi, and another medicine called tezacaftor ivacaftor, also known as Symdeko. Lumacaftor and tezacaftor, they are correctors. So these are medicines that were shown to be helpful for 2 copies of delta F508. So this is that mutation where you don't get CFTR that makes its way to the cell surface where it needs to go. So again, in this hand-waving kind of way, lumacaftor and tezacaftor, they're correctors. They get that mangled CFTR protein into a form that allows it to go to the cell surface where it doesn't still work normally, but following treatment with ivacaftor to help potentiate it, works. So Luma-Iva came out first. It was shown to have a statistically significant but quite modest improvement in lung function. Like we're talking about several percentage points compared to the 10 plus percentage points we were seeing in people treated with ivacaftor and those class 3 mutations. But it was shown to help reduce those pulmonary exacerbations, which is a bit of a win. Tez-Iva had similar efficacy. It also reduced pulmonary exacerbations. It was better tolerated overall versus Luma-Iva in terms of side effects. Also, on an aside, Tez-Iva shown to helpful for people who have like a 508del and a residual function mutation. So overall, the spirit of this slide is to say that we're getting modulators for more people overall, but we weren't quite there yet. And you can look at my citations down at the bottom. So this was around 2015, 2017 that these medicines came out. It was in 2019, though, that 2 landmark papers came out on this triple combination, highly effective modulator called elexacaftor, tezacaftor, ivacaftor. This was and still is a huge deal. So elexacaftor is also a corrector, but has been shown to function as a potentiator as well. This medicine was studied in 2 studies that got published pretty much like within the same month as each other. One study looked at people who have two copies of F508del, and the second study looked at people with one copy of F508del, and their second mutation was a minimal function mutation, i.e., a mutation that would or i.e., that second allele would pretty much contribute very, 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 very little to no function at all. And we were seeing these significant increases. I know that when we just look at FEV1 changes on a page, things are a little bit dry. Things are a bit it's so what? But really in practice, again, we're seeing this medicine rescue people off of a lung transplant waiting list. People are feeling so much better. There are literally some people with CF who stop coughing on this medication. It still is huge. It has been approved by Health Canada for people as young as 2 years of age, with the understanding that the first round of approvals came out for the adult population, and they're working their way downwards as we gain more experience and evidence about this medication. The medication is available in every province and territory in Canada, with coverage criteria varying depending on the province. Jurisdiction, to be exact. Real life ETI observations. So lung health typically improves. I mean, as an example, right now in our prairie lung transplant program, unless things have changed in the past couple of months, I don't think there are any people with CF currently listed for transplant. We're actually in an era where for some patients in appropriate situations, with the understanding that there's a fair bit of uncertainty about things, we have discussions about de-escalation of certain aspects of CF lung care. Although that's also kind of a huge discussion topic on its own that if you guys are curious, we can talk about at the end. Ultimately, while pulmonary exacerbations don't occur as frequently, though, there are still totally people who still need oral IV antibiotics and hospital admissions. CFTR, as many of you are aware, gets expressed in the sinuses. Sinus symptoms will often improve. When ETI came out, there was some hope that it would just melt away a lot of CF complications. Unfortunately, I think we're at the point where we know that that doesn't exactly happen. So for instance, in terms of the gut symptoms, some people might feel a bit better, but the truth is most people are either no different or in some instances actually worse off. We face various side effects, including things like weight gain, worsened mental health, amongst others. CF care just remains busy, but in a different kind of way. But regardless, we are just delighted with how well some of our patients are doing on ETI. So where are we now? The majority of people with CF, thanks to ETI, are doing better. The majority of people with CF can potentially benefit from ETI on the basis of their CFTR mutations. There is actually, we know that non-F508del mutations have the potential to respond to ETI. So there's work being done on rarer mutations and whether ETI can work on them. And this is relevant because there are some incredibly, incredibly rare mutations out there where it's just not feasible to conduct a full-on RCT. So there are some, for instance, in vitro, lab-based assays, which are being used to see whether certain mutations might respond to modulators. There are other CFTR modulators other than ETI, which are being researched. At the end of the day, though, not everyone with CF are able to tolerate ETI. And, I sure as heck hope that our ETI benefits last forever. But in the back of my head, and I know that I'm not the only one who thinks about this, there are still some uncertainties about the long-term durability of the ETI response. For people who have two nonsense mutations, so two copies of premature stop codon mutations, no working CFTR. If they don't produce any CFTR at all, the idea of using modulators to restore CFTR function is not going to work because there's just nothing to modulate. There's research being done on read-through agents. So medicines that might allow, for the skipping over of the premature stop codon, mRNA-based therapies, there's always going to be a role for mutation agnostic therapies. But really the holy grail in CF treatments would be something like gene therapy, which has the potential to treat everyone with CF. There have definitely been attempts at doing this over the years in research, but we just haven't gotten to the point where there's sufficient clinical efficacy to be put into widespread practice. Um, on an aside, I've just, I came into the CF field just about a decade ago because it was like 2013 to 14 when I did my clinical fellowship. That it was around that time that ivacaftor was, it was being used. We were seeing that it was helping patients out. And it's just been like exponential how fast research developments have come out. So now that we're in the era of like highly effective modulators with ETI, there is like all this enthusiasm for developing even more advanced therapies. Going back to what I was discussing earlier, though, that gene therapy, it's hard. I mean, there are various challenges, including but not limited to developing that effective vector. That vector needs to reach appropriate cells, despite, this thickened mucus layer, the innate lung host defense, mucociliary clearance. So gene therapy for CF lung disease, difficult. Um, I thought I would just, include a few slides about pulmonary ionocytes, which is a topic that's near and dear to my heart, relevant for this particular discussion about gene therapy. I'm going to be cramming a fair bit of, well, I'm going to summarize a fair bit of information into a few slides, but some of you may have heard that back in 2018, there was a newly discovered airway cell type, which is like really cool because, who would have thought that in this current day and age, as recently as 2018, new cells would actually be discovered. So there were two papers published in Nature, like pretty much in like the same same what's the call art like not like it, same journal the same like pretty much the same day that it came out together. That's I'm kind of having word finding difficulties, but anyway, these papers showed using RNA sequencing that there are these things called pulmonary ionocytes that comprise just 1% of airway cell type. So they're very, very rare, but they express CFTR at a very high level. So that led to people in our CF field wondering, maybe there needs to be a paradigm shift. Is it possible that this incredibly rare cell population actually plays this very important role in CF lung disease pathophysiology? There was a subsequent paper that did show that when you take into account both the prevalence of cells as well as overall CFTR expression, yes, ionocytes express the highest level of CFTR per cell compared to all airway cells. But these authors propose that, when you take into account cellular prevalence, other cells are actually maybe, playing a higher level of CFTR expression. There was another paper published last year in Nature showing that using the transgenic ferret model, that ionocytes are involved in sodium chloride bicarb transport. And the authors actually proposed that ionocytes play a role in regulating airway surface liquid volume, pH, viscosity, mucociliary clearance, which is a very, very tempting and provocative idea because, even if these cells, aren't the most common cells, is it possible that targeting these cells for correction could actually fix all of the important hallmarks of ASL abnormalities? So, as I mentioned, our team has been looking at ionocytes as well. What sets us apart, though, is we have expertise in a technique called self-referencing ion selective microelectrode, which we refer to as SRISM. So this is a technique that actually allows us to study cells at a single cell level. For our study, we used human bronchial epithelial cell cultures from CF and non-CF donors. We used something called MitoTracker to screen for the presence of ionocytes and club cells because this dye helps us pick out mitochondria-rich cells, which is to be expected in ionocytes and club cells, which are a kind of secretory cell because of their role in ion transport. And we're later able to confirm the identity of the cells using other cell-specific antibodies. I suspect most of the audience doesn't look at ion flux charts, but in brief, so row 1 refers to sodium flux, row 2 refers to hydrogen flux, row 3 refers to chloride flux. We found that for hydrogen flux, following stimulation, there is negative flux in non-CF cells, which indicates the movement of hydrogen ions out of the lumen. Remember, in CF, acidic airways happens, not good. So, making the airways less acidic is actually more of a healthy sort of phenotype. This, however, does not happen in cystic fibrosis, but this mechanism is restored after ETI treatment. Taken together, we believe that ionocytes regulate airway pH, but not necessarily airway hydration. We also looked at club cells. Here we are seeing positive ion flux of sodium and chloride in those non-CF cells after stimulation. This would indicate the movement of sodium and chloride into the airway lumen, indicating that club cells have a role in regulating airway surface liquid hydration volume. This process does not happen in cystic fibrosis, but does get restored after ETI treatment. So taken together, we believe that, again, ionocytes play a role in airway surface liquid pH regulation. Club cells are primarily responsible for airway fluid volume regulation. Fixing one cell might, fixing ionocytes could restore pH abnormalities, not necessarily volume abnormalities, and the inverse would apply for club cells. There's a complicated cellular ecosystem within the airways, and I really do think that future gene therapies will need to take into account this concept. If you are wondering, how do we reconcile our results in the context of the Nature paper, different experimental models may well be contributory. At the end of the day, and this is maybe my way of, critically appraising an article which has ostensibly been published in a very, 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 very high-ranking journal. When it comes to ion transport at a cellular level, there are influences from things like overall membrane potential, paracellular pathways, interaction with other cells. We don't necessarily know what gets changed with genetic manipulation of certain animal models. There is going to be some philosophical debate, because I know that there are some other scientists who will really stand by the idea of using these transgenic models to achieve the absolute truth, which is a very, very difficult thing to study, because we would otherwise need to have these detailed assays in living, humans, which really isn't feasible with the technologies that we've got. But overall, our team is very happy that we're able to help advance CF science in our own way. All right, switching back to clinical practice. So I imagine some folks in the audience may be taking a bit of a sigh of relief. We're going to run through a series of CF complications, and I'll help contextualize certain things to help it be relevant in your anesthesiology practice. All right, starting with pancreatic insufficiency, the majority of people with CF are pancreatic insufficient. They need to take pancreatic enzyme replacement with food. Interestingly, pancreatitis, acute pancreatitis, actually quite uncommon in our insufficient patients. Oops, sorry. CF-related diabetes. So it is due to pancreatic insufficiency, although insulin resistance also plays a role. I encourage the medical learners I work with, just call it CF-related diabetes, because that's an all-encompassing term that just reflects all of the markers of the condition. I remember back when I was a junior resident, I was like, if it's not type 2 diabetes, is it just type 1 diabetes? No, it is not type 1 diabetes either. Just call it CFRD. Interestingly, DKA is rare in CFRD, and this is because there is usually some residual pancreatic function at hand. In the 2022 registry, it was described in 22.5% of Canadians. It is traditionally most commonly treated with insulin, but there are some instances where a person may get treated with oral medications as well. All right. Okay, so this is a chart showing the age breakdown of people with CFRD. The x-axis not completely even, but it's just to show that the majority of people with CFRD are adults. It has been associated with poor lung function. Poor diabetic control has been associated with worse outcome following exacerbation. So even as someone who typically does not manage diabetes outside of the in the general population, I mean, I have vested interest in this. I mean, I'm very, very grateful to have wonderful colleagues with expertise in diabetes support me in the care of our patients with diabetes. Abdominal pain and discomfort. This is a huge issue in our patients as well, and I really don't think it gets enough attention outside of the CF community because people generally talk about lung stuff. There are various reasons for this, including chronic constipation. Unfortunately, ETI, I mean, it was not able to melt away abdominal discomfort in many of our patients. In fact, some of our patients actually feel worse in their guts than they do in their lungs now. This is a topic that I really hope I mean, it is getting more research, and I am happy about that. DIOS, which stands for distal intestinal obstruction syndrome. I really, really wanted to include a couple of slides on this for this presentation because this is a complication that is very, very, very well known about in the CF care community, but much less so outside of it. It is a CF-specific complication where a person may actually present like having an acute bowel obstruction. It is not uncommon at all in our patients. And it's characterized by a triad of abdominal discomfort, right lower quadrant mass on physical exam that actually represents this like stool-filled loop of bowel, and abdominal imaging that reveals right-sided fecal buildup. There are going to be some instances where a person may have complete DIOS, where pretty much things are utterly blocked up, and other folks who may have incomplete DIOS, where things are still passing through. There is a bit of a continuum between chronic constipation to DIOS. But again, there are some instances where people may present to hospital practically with an acute abdomen. There are various risk factors for this, including pancreatic insufficiency, dehydration, like insufficient pancreatic replacement, GI dysmotility. The truth is the vast majority of these cases can be treated medically. I mean, I don't ever want to come across with too much bravado because I know that there totally are some instances where surgery may be required, but it always makes CF clinicians sad if we find that a person with DIOS was treated with surgery without an attempt at medical therapy first, assuming that patient was, in a state that was fit for medical treatment. So if you ever, come across a patient in a pre-op for consideration of, a surgery for acute bowel obstruction, if their CF team hasn't already been notified, regardless of where you practice, I promise you the CF team will be very, very happy if they get a heads up about these cases. Okay, we're almost on the home stretch of our presentation. So colorectal malignancies and CF. People with CF are at increased risk of developing colon cancers. There are various reasons for this. CFTR has been actually proposed to be a tumor suppressor gene. And and for that reason, for the increased risk of colorectal malignancies and CF, the guidelines actually propose screening patients with CF earlier. So all patients with CF are recommended to undergo screening starting at the age of 40. And people with organ transplant should actually start getting screened at the age of 30. Colonoscopy is currently the recommended test for this particular indication. Just shown on that right-hand slide is, for context, is what Cancer Care Ontario recommends for the general population. More intense colonoscopy prep is recommended. CF bowels can be incredibly difficult. Our PEG electrolyte solutions don't go nearly as far. So people are recommended to have more aggressive preps. There was actually a single center study which compared standard protocol versus modified bowel protocol and showed that their modified protocol, which to be fair was more aggressive than what the CF Foundation had recommended, they showed that there were more good preparations, fewer poor cleanses, and a higher rate of adenomatous polyp detection. So whenever I refer my patients for colonoscopy, it is typically to colleagues who, there are, certain colleagues who are quite familiar with CF already, but if there is a new colleague that I'm referring patients to, I'll always just give them the heads up about this and include a sample colonoscopy prep regimen that they can consider prescribing to their patients. Osteoporosis, not an uncommon complication in our patients. There are various risk factors for this, including some which are quite CF disease specific. We know that bisphosphonates have been out there for quite a while, but it has been shown that people with CF have increased bone turnover, increased measures of like rank ligand. So there are some folks who wonder whether a medication like denosumab, which is a soluble rank ligand inhibitor, may have a role in treating osteoporosis in CF. CF liver disease, the main hypothesis is that dysfunction in the CFTR in protein and bile ducts eventually lead to abnormal biliary secretions, retention of those bile acids, localized inflammation, fibrosis, with some other factors being possibly contributory as well. Urinary stone disease. This is also a bit of a thing that, well, no, this is a topic that I also wish gets more research and attention because people with CF are actually at increased risk of developing kidney stones. There are people whose lungs are doing great, before transplant, after transplant, whose stones actually cause the bulk of their quality of life issues. Various reasons for this could include like loss of oxalobacter from the GI tract. So this organism is responsible for degrading oxalate in the guts. If this organism it isn't there in sufficient quantities, there's increased oxalate from the guts. Unabsorbed fats can bind to calcium, reducing binding to oxalate, again, increasing oxalate absorption. It is possible that there's abnormally low intestinal oxalate secretion as well using an animal model. I'm going to maybe just blast through the last few slides because I know we're kind of getting close to the end of time, but we know that the vast majority of men are infertile due to congenital bilateral absence of the vas deferens. Women with CF can conceive naturally, but there are various reasons for infertility, including thickened cervical mucus. We always make a point of discussing fertility with our patients in clinic. We are always happy to make referrals to fertility clinics, especially for our male patients who would typically require assistance with fertility treatments like IUI. When our female patients become pregnant, we refer them to our wonderful maternal fetal medicine colleagues. We adjust their meds as needed and follow them during their pregnancies. There have been more pregnancies in recent years in the context of more widespread ETI use. This may be from increased confidence in health related to the medication use of the modulator, but there are also reasons to suspect that it may also be helping correct those aforementioned barriers to fertility, because unplanned pregnancies in people with a history of infertility or subfertility have also been described. So how it translates into clinical practice, we make a point of counseling our patients, educating them about how, for our female patients, if they aren't specifically interested in becoming pregnant, we do encourage them to think about use of a reliable form of contraception. Finally, cardiovascular disease. This is most likely an emerging risk in our patient population because our patients are living longer and longer. The high-fat calorie diets that were previously recommended for our patients, they may no longer be quite as applicable now. In the past, coronary artery disease was thought to be quite rare, but there are emerging case reports and studies. And there was actually a study published in ERGA using registry data that showed that people with CF are at increased risk of developing cardiovascular disease, major adverse cardiac events driven primarily by MI. So this is something that I do worry about. Overall, MI and CF still quite uncommon, but I'm going to keep it on my differential diagnosis. Okay, we've got a few other unanswered questions, including best models of care for people with CF through their lifetimes, geriatric CF issues. Are we potentially going to be seeing this wave of CKD because some of our patients have been exposed to nephrotoxic medications like antibiotics over the years? Here in Saskatchewan, we have one adult CF clinic, one adult CF clinic here in Saskatoon, a peds clinic in each of Saskatoon and Regina. We offer multidisciplinary care. Practical points. People with CF are very familiar with their health and medications by and large. Some people who are sick don't always look sick. So the eyeball test doesn't always apply to our patients, unfortunately. FEV1 is an important marker of lung function tracking in our clinical practice, but it doesn't always reflect the level of physical function. So there are totally people who have FEV1 less than like 50% who actually do quite well. If there are concerns about airway secretion clearance after surgeries, please consider a physio consult. CF clinics are always happy to collaborate and help. Personally, I'm always happy to be called about my patients if any of my colleagues have questions. Key points. Survival of CF is increasing over time with improved therapies. CFTR modulators like ETI have led to improved health in people with CF, but there's still people who can't benefit from modulator therapy. DIOS is a not uncommon complication of CF that can often be treated medically. And lastly, as people with CF grow older, our care community faces questions that are yet to be answered.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.